I just would like to quickly welcome everyone to this webinar as part of the Implementation Science Collaborative series on mental health and psychosocial support. Thank you so much to our co-host, City University of New York, and the East Central Southern African Health Community. I'm going to pass it over to Vicki No from CUNY to kick us off.
Good morning, everybody. Good afternoon, good evening to some of you. We are so excited to have today's programming. Today's webinar is entitled Reaching Policymakers in Mental Health and Psychosocial Support, Evidence Translation and Service Integration. And we will be featuring a panel discussion that will be focused on strategies to reach and engage policymakers in the uptake of evidence-based mental health psychosocial programming. It'll focus on examples from Africa, highlighting current policy directions and lessons learned from Africa Center for Disease, as well as the SMART DAPR project, which is a depression primary care integration focused on depression and post-traumatic stress disorder in Africa. And then following that, we will have a panel of policymakers, implementers, and funders who will discuss the implications for future and present opportunities and best practices for synergizing efforts and to ensure the translation of evidence into practice. I'm joined today with my co-host, Rosemary Masaka from the East Central and Southern Africa Health Community, EXA-HC. And our first speaker following Rosemary will be Susan Murford, who is leading a large-scale depression primary care partnership, the DAPR project, and she'll be speaking after that. I'll pass it on now to Rosemary, who will lay out some of the issues for us. Thank you.
Thank you so much, Vicki. Good morning, good afternoon, and good evening to you all. I also like to invite you, all of you, to this important, it's a second series of our webinar on mental health and psychosocial support. And we are going to see how can we reach the policymakers. And that's why we have a diverse of participants today. But ideally, we have to see how can we translate the evidence and integrate the mental health and the psychosocial support in our. So we know that the whole agenda of mental health and psychosocial support, the whole topic has been increasing more or getting more attention with the following the COVID-19 pandemic. And now the policymakers, as well as the programmers and researchers, understand that it's high time that we have to spearhead the agenda and increase the integration, as well as they address the capacity gap which have been observed in most of our interventions. And in most of our ministries or respective areas, we can note that it was not given enough priority. The mental health aspect were not given enough priority. And we have seen that with the opportunity is there now. We have seen how the COVID-19 pandemic has hit all of us and how important the aspect has been highlighted. It's high time that we need to be informed with the current evidence, guidance from the global as well as regional level on how important it is. And we are together today. We have a participant from the policy making organization. We have participants from the research institutions and colleagues from the Implementation Science Collaborative and other research institution outside this arrangement, as well as the policy makers from ministries of health and the programmers, various partners who are implementing the mental health and psychosocial support. So it's high time that we have to ride on the increased political commitment. We'll have an opportunity to hear from the Africa CDC on how they have recently developed the non-communicable diseases, mental health and injuries strategy, to hear how the evidence how can we translate this evidence to spearhead the agenda, and how can we convince the policymakers and bridge the gap between the professionals and other key stakeholders to see how can we integrate the mental health and the psychosocial support in future emergency preparedness and response plans. So I welcome you all and looking forward to learn and hear from all the colleagues who will be having an opportunity to present. Thank you so much.
We're just waiting for the video to queue up for Susan Murfitt.
Hello, my name is Susan Maffert. I'm an associate professor of psychiatry at the University of California, San Francisco. I'm delighted to be here with you today. I'm going to be speaking quickly to tell you a little bit about the SMART DAPR study, which has been ongoing in Kenya. I'm an MPI in the study. The other MPI is Dr. Muthoni Maathai, who's at the University of Nairobi. And I'm going to begin now with the sharing of my slides. SMART DAPR is a mouthful to say because it's supported by two different R01s from the NIMH, and they constitute the SMART and the DAPR respectively. Just to begin briefly with a quick look at the global burden of disease from 2019, focusing on East Africa and mental disorders in that dark blue. Just want to point out the massive burden of disability, YLDs on the y-axis, and disability beginning in young adulthood. The reason why, of course, is that 75% or more of people with serious mental illness never receive any treatment at all. And that number is even higher than 75% in many regions of sub-Saharan Africa. Which disorders are we talking about? They're nothing scary, exotic, or frightening, much to inconsistent with many public conceptions of mental disorders as frank psychosis. In fact, they are everyday things like depression and anxiety that create the most burden, things that we or our friends and family members have all experienced. Just noting also, there's been this huge increase of both depression and anxiety since the onset of COVID. Lest we think that depression exists only in high-income countries, that is most certainly not true when we look at the data. If you look all the way over on the right-hand column, you can see the world put together with women, as usual, having a slightly higher rate than men, over 5% of the general population. But if we look at the left-hand column, we can see that the Africa region, women living in Africa and men living in Africa have some of the highest levels of depression in the world. Certainly not a problem that just exists in the US and Europe. I won't go into detail on this slide, but I wanted to mention it for this policymaker audience. There are massive economic consequences for failing to treat depression. It's extremely expensive to leave depression untreated because it results in decreased performance at work, decreased income, decreased tax base for governments. It also incurs huge physical healthcare costs because people with depression keep going back to the doctor, and the doctor keeps ordering various tests and specialist visits that don't have anything to do with treating the depression itself. They're presenting with things like headache or stomach ache, and people are missing the fact that this is simply depression that needs treatment. Happily, we have a great net rate of return when we treatment. For every dollar we put into it, we get about $3 back in increased productivity and decreased healthcare costs. The background of this study, we work with Kenyan and Ugandan ministries of health and our key stakeholders to treat a major depressive disorder and post-traumatic stress disorder in a primary care adult population in Kisumu County Hospital, to be specific. This is our team. I want to highlight that we have from the very beginning included high-level policymakers, including Dr. Simon Njuguna, who's head of mental health for Kenya, and many others that I'll let you review there. Our outcome cores and deliverables include heavy focus on economic analyses and creation of a health policy menu, health policymaker menu, so that policymakers can select a package of care that matches with the finances that they have available. Briefly, this is our study. It uses what's called a SMART design, a first-line treatment randomization followed by second-line treatment randomization. And importantly, we use an implementation science model to guide our thinking from before we even launch the study all the way through the conclusion of it. This includes stakeholders and annual meetings with all of our stakeholders focused on how we can change the study within scientific parameters to achieve better sustainability and better scale up and better relevance to policymakers. This is just one model among many, but we like to use the EPIS model. This is briefly a little bit of information about how we adapt the study as we go forward to make it more relevant for policymakers. And one of our goals is to make sure that the study that we do at one county hospital in Kisumu is relevant across various counties in Kenya and also in Uganda. Our most recent IRT meeting happened just last month, and that's our implementation resource team meeting of all of our stakeholders, including lots of policymakers. And then, of course, all the way across every level, the hospital administrators, the community health workers, the providers of treatment in our study, and most crucially, the patients who receive the care, the users. So far in our study, we've screened about 3,800 people, and we've enrolled and randomized about 2,000 people. We've had extremely high retention in our study, just under 95%. And I'll be talking about that a bit more in the future. In these slides. Importantly, during COVID, we had to transition to delivering mental health care via flip phone, not smartphone, because we couldn't be sure that everyone had access to a smartphone with video capabilities, but we knew everyone had access at least to a family flip phone. So during COVID, we transitioned to making telephone treatment optional. We also allowed people to continue coming in, but we wanted them to be able to have the option to do their care and assessments over telephone in case they had COVID or were worried about getting it. We found tremendous acceptability of telephone treatment, even at baseline, and that has continued to increase across the study intervals. In terms of our baseline data, about most of the people in our study so far, about 86%, have both major depressive disorder and PTSD. And in terms of violence that would be driving the PTSD, we have a great deal of intimate partner violence that we see. Over half of our study population have had intimate partner violence in their lifetime, and about 18% over the past week. Lots of people with high levels of different types of trauma over their lifetime. And the disability score was very high. This is what we were talking about beginning with the YLDs. We saw in our population, we have seen so far in our population that at baseline, people come into the study, they're so disabled that they're missing at least 8 days of work every month due to their health condition. In terms of fidelity and adherence, that means patient attendance of their study treatments and the non-specialist adherence to study protocol, both have been extremely high. We see that for the IPT arm, the psychotherapy arm, people are coming in, making their appointments more than 95% of this time. With fluoxetine, the medication arm, we see they're coming in and taking their medication about over 80% of the time, and the provider, non-specialist provider adherence to protocol is also very high. We look at the treatment costs. We did this carefully, again, with our attention and our eye on policymakers, knowing that they need to make tough budget decisions when it comes to health budgets. We have analyzed so far the cost of providing IPT and fluoxetine. This is a slide showing the provider costs, and the second slide combines the provider costs with all the other costs, including the cost of the medication for the fluoxetine arm, the cost of supervision, even the cost of second-line treatment for those few that need it. And we come out with something quite low already for fluoxetine. It's about 37 USD. That's those are in Kenyan shillings. That comes out to about 36 USD, 37 USD. And IPT currently is a little more expensive at 93 USD. In terms of our other economic productivity data is quite exciting so far. We have seen that only about 62% of our participants were even earning a monthly income at baseline, any type of income that includes informal income, not just wage. But at month 9, when both randomized groups had already received their first-line treatment, we were already up to 75%. In addition to that, not only did more people earn an income, but those people who earned an income earned a great deal more. So this is the amount the amount of shillings that people earn per month. And we can see this huge jump already at the 3-month time point, which is the conclusion of IPT, but fluoxetine is still going on. And then going out to month 9, we see an even further jump up. So when we look at this, of course, this is really exciting for the participant and the household that they have so much more money in their pocket. It should also be of interest to the government. Essentially, if you think about the tax base that this represents, the treatment has already paid for itself at month 3. Likewise, we see that in terms of the days over the past month that people were partially or totally unable to work, there's a dramatic decline. Remember, I mentioned that at baseline, about 8 days out of the month, participants were either partly or totally unable to work due to a health condition. We see this dramatic drop down to less than 1 day per month that they were totally unable to work out at month 9. So evidence to policy takeaways, our study in terms of recruitment rate and adherence to care demonstrates a huge unmet need and demand for depression and PTSD outpatient treatment among these public sector primary care patients. In Kisumu, we have demonstrated the feasibility, acceptability, and scalability of non-specialist evidence-based clinic integrated care for depression and PTSD, including both face-to-face and mHealth treatment delivery. And we have shown with our preliminary data, high economic return on depression and PTSD outpatient mental health services, even during the severe COVID-driven economic downturn in Kisumu. So I will stop there. And put our information up, both mine and Dr. Mathai's, for any follow-up questions. Thank you so much for your time.
Thank you. That was so great. Such exciting work happening. We are very fortunate to also be joined today by Dr. Dusami Njoba Mamba, who is the mental health officer of the Africa CDC, and I'd like to invite him to the discussion now.
Good afternoon, good morning, good evening. The name is Tumsani Mamba, Africa CDC Mental Health Technical Officer. It is an honor and a privilege for me to be here doing a presentation on behalf of Dr. Mohammed and Dr. Adelat, who were initially going to be the ones doing the presentation. I'm going to take us through what I would say it's a very brief presentation on what Africa CDC has done and is doing with regards to the integration of mental health psychosocial support in emergency preparedness and response across the continent. The first thing I would like to highlight is we recently we just came out from launching a document which I would say is an achievement and a milestone for Africa CDC, the launch of the non-communicable and diseases and injury mental health strategy, which is like the first strategy by Africa CDC. This will actually speak to what we have always been missing as a continent with regards to mental health and integration of mental health services into emergency response and preparedness. So from Africa CDC perspective, I think we might probably all be aware how Africa CDC operates. We work with member states, we work with the ministries of health, we work with the National Public Health Institutes, where we integrate and work with them in terms of providing technical support, providing resources if available, and also providing support and in nurturing and establishing health systems that are going to be stronger for the continent. So the first thing one would want to highlight is with the validation of this document, the document has been developed through a very consultative process, which was, I would say, it's the bottom-up approach. Since with Africa CDC, we are serving member states. So most of what is in the document is a document created and formulated by member states through coordination by Africa CDC. We have done consultations with the ministries of health through the NCD's department, mental health department, but for for the interest of today's discussion, I'll focus more on the mental health aspect, that we have consulted with mental health experts across the globe and across the continent specifically and mostly. And we have also consulted with people with lived experience, because we wanted to make sure we integrate everyone and we have everyone as part of this document that we are working on. So the document was validated last week with member states from all walks of the continent. To be specific, we had 42 member states participating in the validation and launching of the document, which is a very good number, considering that we are a continent of 55 member states. So having 42 literally says we almost had everyone. And for those who were not able to come through, they had contributed to the development of the document. To get us started, there's one would want to ask, where is the continent going with regards to MHPSS and what strategies are in place? The first thing I would want to highlight is, as Africa CDC, we have a division that specifically looks at emergency preparedness and response. And as the mental health unit, which is housed under the Division of Disease Control and Prevention, we are working hand in hand, trying to make sure that integration of mental health and psychosocial support is an integral part of our sister division on emergency response and preparedness, because we have realized, as we have been speaking and we have heard from the presentation just made just not long ago, the previous one, about the evidence that speaks to mental health and mental health being an integral pillar of health systems. And as Africa CDC, we are very cognizant of that, and we are very much aware of this is what we need to do. And as different divisions within the same institution, the biggest thing we can do is working hand in hand in making sure we integrate mental health into emergency preparedness and response. And that is evidenced by one of the biggest objectives we have actually in the strategic document, which is objective number 1, which reads enhancing the capacity of ministries of health and PHIs to develop, integrate, and implement national policies and supranatural frameworks and policies for mental health prevention and control. That basically speaks to how are we as Africa CDC seeing mental health as a priority in the integration of mental health in emergency response and preparedness, and also in health systems, because one of the biggest mandates for Africa CDC is health system strengthening. And we cannot do that if we've got shaky emergency response systems. So that's one of the biggest objectives. And as Africa CDC, we are very proud about that, since it's something that has been lacking in one of the things that we're working on, mental health, as it was said by Rosemary earlier in her opening remarks, that there has been a lot of neglect on mental health. And with that, it has also been neglected in situations where you definitely need to have a mental health system in place, which is in emergencies and response. So with this particular objective, we are very excited that we are doing something to integrate and make it within the national policies of the member states, because this document was developed by member states. It's not Africa CDC telling member states to ABC. It's member states requesting assistance from Africa CDC in integration of MHPSS and emergency response and preparedness plans. And with that being said, one would also wonder then that we have a good document as we want to see it being a good document. We're looking at what's the commitment that comes with it. What is there that is going to be binding, that is going to be enforcing and influencing member states to do these activities? From where we are as Africa CDC, we are working with member states, like I've been saying, and the biggest thing that we have is the political power of the African Union. Because Africa CDC is a public health institute of the African Union, where the members or the heads of states sit together to discuss Africa issues, particularly health issues, driving them through Africa CDC. When we have this kind of a document coming from Africa CDC, we are literally having a document that can wield certain power to the member states to say, now we have this, we have to integrate this, because it has been endorsed by the African Union, which literally binds everyone who is a member state who participated in the validation of this document to say, in all the national emergency preparedness and response plans, we need to have a pillar on MHPSS, which is one of the biggest things. And as we are working around with that, I would just want to highlight that in the people we had participating in the meeting last week, we had 7 ministers coming in for this meeting to endorse and validate this strategic document, to say, we know it's here, we appreciate it, and with the political influence of ministers present, we know we have commitment from all the member states, from all the governments, from all the heads of state that are subscribers to the African Union charters, and particularly to African Union public health issues, as it has been seen in COVID-19 and all these other emergencies that have been popping in the continent. And that brings me to another component of it. I just want to highlight that we have already started. It's not that we were waiting for the document to come in place. Early this year in February, Africa CDC, in partnership with other collaborating organizations within the African continent and internationally, we had a regional workshop on the integration of mental health and psychosocial support in one of the regions, which was in the West, having countries like Liberia, Sierra Leone, Cameroon, Nigeria, and other partners participating in what was a workshop to learn more about the experiences we have as a continent in responding to emergencies, lessons learned, and what we can take out of it, and also developing what we call the theory of change, which comes with pillars that speak to the what can be done to make integration of mental health and psychosocial support even more effective, reacting and intervening on the challenges that have been faced by the continent. In just a short while, I'll just share a brief, I'll say I think it's 4 or 5 slides, which speaks to the findings and feedbacks that we got from that workshop where member states were participating with different partners. With your permission, Chairperson, I can just project my screen shortly to just show the presentation on the feedbacks from the workshop we had in Liberia with colleagues. I'll just start from the workshop summary just to give an overview of what really was happening in the training that we had in Liberia. The first thing is we had an attendance of a couple of organizations and partnering institutions, which I would say we call it the Mental Health Consortium, which is made of Africa CDC, WHO, AFRO, WAHO, EXA, UK Public Health Response Team. These are some of the countries, organizations that participated in addition to the countries I mentioned, which is Cameroon, Liberia, Nigeria, and Sierra Leone. We had an attendance of more than 50 people. It was a hybrid workshop. Some were joining online and some were there physically, including myself and a colleague on the call, Rosemary, who was part of that. And as I had said, the biggest objective of the workshop was to establish regional networks to share learnings and expertise on different emergencies in the continent, on how we have been responding as a continent to that. And in addition to that, it was also to develop the theory of change for integrating mental health into national emergency prepared and response plans. That was the biggest of all the objectives we had for this meeting. And from what transpired in the meeting was most of the key barriers that the participants made obvious to us were that in order for us to integrate MHPSS into emergency preparedness, the biggest problem was the lack of political will. You would remember that earlier on I spoke about the importance of the African Union and its political power and the political will it yields in terms of influencing member states to have certain things going on within their different countries in respect to health. And the other barrier that we realized was the deprioritization of mental health during emergencies. We have seen this, and it was only until COVID-19 that we really had our eyes open that actually mental health is very important when you want to respond to emergencies. And then we had lack of funding. That was a very big one, because in order for us to do anything, you technically need to have the resources to make it work and make it happen. And the lack of availability of trained staff to provide MHPSS activities, and also the non-existing and weak or pre-existing mental health systems, which speaks to basically how mental health has been neglected for over these decades that we have been dealing with emergencies, dealing with strengthening health systems. We have been more predominantly focused on these other issues. And speaking of the positives that came out of this workshop, it was one of the biggest things that we need to have a way to integrate mental health beyond the emergencies. We should not say we are responding to COVID-19 and this is what we're going to do. And once we feel like COVID-19 is no longer an emergency, we withdraw the resources on mental health, we withdraw the resources on all the aspects that require funding or resources for sustainability of mental health. So the other big thing was speaks to sustainability of the systems that we are developing, because we should not develop systems that at the end, it's like we're going on and then we say, okay, this finishes here, we stop. And then we have to reinvent the wheel over again and again and again. So these are some of the things that really came out strong from the meeting we had. And I'm not going to be reading through because I have already indicated some of them. And these are as they appeared when we were developing what we call the theory of change, as it is exhibited in this diagram I have here, which literally speaks to the integration of MHPSS into emergency response and preparedness. And you definitely need to have coordination. You definitely need to have information management, funding, and human resource. And all of this, they build one thing. They build effective preparedness and they build effective response, which is also informed by health system strengthening, which is what Africa CDC's basic mandate is all about. And once we have stronger systems, you need to have a way of sustaining the systems. And one would ask, how do we sustain the systems? We sustain the systems through collaborations, through working together, through what I would say is the multi-sectoral approach in dealing with emergencies, response, and preparedness, particularly when we want to integrate mental health into all these systems that we already have in place. I would say this is basically the long and short of it. And over and above, as Africa CDC, we have our activities looked and focused on assisting and providing technical know-how to member states on mental health support, and also on the other aspects, which is the tools to use when you're integrating mental health into emergency preparedness and response, the collaborations, the networks, the pool procurement in terms of even resource mobilization, because as a coordinating body of public health, as in the African Union, we have a mandate to coordinate these activities within the African continent. And that's the biggest activity we have. And right now, the biggest success we have is we now have a document which is going to be a driving force behind all of the what we are speaking about, putting actions on the document and taking a lot of implementation activities down into the ground, influencing member states to drive their policies, to drive their national emergency preparedness plans to what we envisage as the proper national emergency plan, which has MHPSS as the pillar in it beyond the emergency for sustainability purposes. Thank you so very much. I'll end right there. Thank you so much.
Thank you, Dr. Dasama Mamba. That was very, very insightful and really wonderful to see such achievements and developments that you guys have been able to push forward. We're going to hear from a panel of speakers who will speak about the perspectives from the implementers, donors, as well as policymaker. And we'll hear from Dr. Florence Kamazanza Bagana and Ms. Grace Oberlin, as well as Ms. Julie Greer Velati. And please welcome Dr. Bagana. Thank you.
It's good to be here with you virtually. My name is Florence Bagana. I'm a psychiatrist and public health specialist. I'm the regional advisor, WHO regional advisor for mental health and substance abuse in the Africa region. I'm talking about African perspectives. I'm going to focus on the policy perspective, reflecting back on implementation science, and maybe talk about only 3 challenges. The first one is very fast. It is funding. Funding is always a big challenge when it comes to replicating, scaling up. The second challenge is that of people, policy and process. If we're trying to replicate something, we always have to interact with people, and often in the context of conflict, having to deal with the policy aspects and the policy negotiation, and sometimes if it's an emergency, conflicts or complex emergencies, infectious agents, we're in a rush, we want to implement in a hurry, and yet we have to do the work that has to be done. And these two can be conflicting. They can be conflicting if you want buy-in, but at the same time you want the full engagement of the policymakers, then that may cause some delay. And the third one is that of where was the evidence generated? As an example, sometimes evidence is generated. We have a lot of conflicts here in the Africa region. We've had conflicts, we've had other complex emergencies, we've had Ebola, and as a result, a lot of the evidence is generated here in Africa. But if we say that we want to replicate it, let's say right now, if there was a need to replicate something where the evidence was generated in Africa, but it's to be replicated in the Ukraine as an example, what will be the uptake? Very often there's a feeling that something coming out of Africa, we have to do it for ourselves, and we're not going to take that. We want something where the evidence has been generated right here in our own country. And this is only an example. I'm not saying that it has happened. It's only an example. Many countries are like that. Even within countries, something where the evidence was generated in another region, or we would like to do something in one region where we have evidence from another region or another district or another province. Often they say we want to first confirm and have our own generation, our own evidence generated. So this can be a challenge. So you may have evidence for something that works, but you cannot replicate it for that reason. Thank you very much. These are three very brief issues I would raise. Thank you. Bye-bye.
Thank you, Dr. Bragana. Okay, next up, we have Ms. Grace Oberlin, who is the MHPSS advisor from Transcultural Psychosocial Organization, TPO, in Uganda.
Thank you. Thank you so much, the moderator. I must say that it's very interesting and so exciting to listen to all the presentation, but most importantly, I think what is very exciting for me as an implementer is to listen to African CDC, get to learn that there's a mental health unit, but most of all get to hear that African CDC has been able to come up with a mental health strategy. This is, I think this is a very big win and a very big plus for us implementers in the field. Like the moderator said, my name is Grace Oberlin. I'm a clinical psychologist by training. And I must say I'm very privileged to hear that one of my mentors and lecturer, Dr. Mathai Muthonia, is on this call. It gives me more confidence. I work with a national NGO in Uganda that is called Transcultural Psychosocial Organization, TPO Uganda. It's a mental health-based community NGO that has been implementing mental health services in Uganda for the past 29 years with a scope of operation in about 48 districts. I'm going to speak today from a perspective of an implementer and looking at how can we use implementation evidence to bridge the gap or even inform policy decisions that exist. I want to start by saying that I picked my discussion from about 3 focus. TPO has been implementing in Uganda for about almost 29 districts, like I said earlier. And one of the greatest challenges we have faced is trying to have evidence or even trying to have clear documentations in regards to the different mental health and psychosocial support implementation going on around the district or around the country. Rather than doing direct implementation in the field, TPO also takes up a leadership position. We are currently the co-chair of the Uganda National Mental Health and Psychosocial Support Working Group. So one of the greatest challenges we have been able to see is that policies, I want to speak from a Ugandan perspective. We are happy and excited that last year in October, finally, Uganda got the legal document officially amended, appended on and signed and passed off by the government. That is the Uganda Mental Health Act. This is a legal document that binds the implementation of mental health in the country. It had not been revised for over 50 years. And for all this while, Uganda has been implementing mental health using a policy that was very old and that was not coming from a rights-based approach or even an inclusive approach. But good news is that last year in October, the Uganda Mental Health Act came out. Now, I want to derive my discussion from there. One focus I want to look at as an implementer is policy priorities. Most of the mental health related policies that come, if you look at the priorities that are reflected in some of these policies, you realize that they're really so far from the reality that is on the ground there. Looking at an example of the Uganda Mental Health Act, one of the greatest priority in the Mental Health Act is integrating mental health services into the primary health care system of Uganda, meaning introducing mental health into a community-based settlement, community-based setting where everybody can access it. But if you come in and ask me as an implementer, before we even talk about accessibility and integrating it into the primary health care, we are having a very big gap in regards to knowledge, understanding, and awareness in regards to mental health issues. Now, the second priority in this Mental Health Act is that it looks at case-by-case investment into addressing mental health and psychosocial support issues. Now, if you come into direct implementation, you realize that as much as case-by-case investment is a very good approach in maybe responding to some of the key mental health issues that have become a big issue. For example, in Uganda right now, suicide has become a worrying need, and depression, that would be good. But if you go down there, you realize that as you're doing case-by-case investment in addressing mental health issues, there are other pressing issues that are attached or that are precipitating and perpetuating these conditions that need to be addressed. Now, if a policy is focusing at case-by-case investment, meaning some of these priority areas will be ignored. Now, I would like to make about 3 recommendations in how can we bridge the gap using implementation evidence to support policy implementation. First one, I would like to recommend that let us look at mental health response, not as an emergency response. I was very happy when I heard that part of the strategies that is coming from African CDC is looking at a sustainable way of addressing mental health. Most of the mental health response in Uganda is largely around emergency and disaster preparedness. The countries, the districts, or the areas that don't have emergencies or disasters barely even have access or implementation or even service delivery of mental health. So my strongest recommendation as implementer is that, can we look at mental health implementation away from emergency response? Can we come up with a sustainable way where with or without any emergency or disaster, we are having a comprehensive consolidated mental health response strategy globally that can fit not only within the member states, but can fit the low income countries. It can fit up to the local people within the community and are able to access it. My second recommendation is research-based implementation. TP has been implementing for over 29 years in Uganda. One of the challenges I can say very profoundly is that all the funds that we have been getting towards having direct implementation, measuring the impact and having clear documentation has been a very big challenge compared to when we have a research-based implementation. We are conducting a research, trying to validate, check the effectiveness as we implement and provide services to the community. Right now, we have just ended a project that was funded by USAID, and that was on health evaluation and applied research development. We did it in collaboration with Washington University. I must say that this has been one of the best projects. We are implementing to evaluate the effectiveness of one of the psychosocial intervention. Everybody in Uganda is excited. We only did a field level dissemination, but everybody is excited to get the national dissemination so that they're able to adopt this tool, pick this psychosocial intervention and use it, because it was a research-based implementation. So if we can look at directing policies that are focusing and advocating more for a research-based implementation, it will really be very good. Then finally, I would like to look at bridging the gap between implementers and researchers, or the, how should I call them, the educationalists. If you look at the gap that exists between those of us who are directly in the field implementing and my colleagues who sit behind the desk and write for us papers, write documents, share tools, develop the different intervention, is so big that by the time I get a tool from WHO and try to contextualize it to fit into the Ugandan implementation, I would have first spent a lot of resources, both human resource and finance, and then two, spent a lot of time. By the time I contextualize it and it fits into the implementation of the local context in the country, so many things would have taken place. So trying so much to focus that we focus the policy at bridging the gap that exists between direct implementers and the policymakers or even researchers will really put us in a very good place of ensuring that we are providing a comprehensive mental health service delivery, but most of all, ensuring that these different stakeholders that play a key role in implementation and service delivery of mental health are working closely together and are having a good connection. In about 2 minutes, I want to share some of the good practice that we have seen come out for us in Uganda and trying to bridge the gap between implementers and policymakers. One of them has been coordination. In 2017, when the government and the different stakeholders were looking at working on the Mental Health Act, there was a lot of difficulties. But when they created close coordination and with support from UNHCR Geneva, Uganda got an attachment of a technical expert on MHPSS to come and support in consolidating MHPSS implementation in the country, but also provide national coordination to set up the national working group. This working group has been able to create a very good platform and network for coordination and collaboration between the implementers and the different stakeholders. And in this, lobbying with the Ugandan parliament became so easy that the Ministry of Health found it very easy to have the act passed. Right now, we are having a very close working relationship with the parliament, to the point that we had to lobby them to form a Uganda Parliamentary Forum on mental health. Less than a month ago, I was with them in Nairobi, Kenya, doing a benchmarking visit to understand the system in Nairobi, Kenya. How has it worked? Now, this has been on coordination. Now, this is something that is working. Uganda, when we speak about mental health, we still have a long way to go, but these are some of the best practices that we have been able to see that it works. And then capacity enhancement, strengthening the capacity of the people that are in direct response and prevention. We don't have so many technical experts that can respond to mental health. And when we talk about mental health, we talk about comprehensive response, right from community, the lowest level, to the highest clinical level of the pyramids. Now, one of the things that we have seen work so well is the capacity enhancement. Being intentional about building the capacity of the non-technical experts to let them understand the basic around mental health, doing mental health awareness and mental health prevention, and using the community-based structures to act into awareness raising and prevention. This has really worked so well, but I would like to end by saying that it's really very exciting. When I was hearing the doctor from Africa CDC speak, I was like, yes, this is the direction we would like to see mental health globally take. And given that we are in the month of mental health awareness, I would like to appreciate and thank the organizers for this meeting. But most of all, I would like to end as an implementer to call upon the policymakers, the donors, and colleagues, the researchers who are out there, that let us try to be intentional when it comes to trying to bridge the gap, to see that as we are implementing, we are meeting the interests of the other stakeholders. Thank you very much.
Thank you, Grace. That was really wonderful. Great insights. Next, we're going to hear from Julie Greer-Velati, who's the Director of the Office of Education, Youth, and Child Development at USAID Uganda.
So I'm Julie Greer-Velati. I am the Office Director for Education, Youth, and Child Development, as Vicki just explained. And I've been with USAID as a Foreign Service Officer for about 7 years. Before that, I worked for about 10 years with non-governmental organizations and universities, specifically working on mental health and psychosocial support and child protection. So in the course of these different stages of my career, I've worked in Chad, Haiti, the United States, of course, Mexico, El Salvador, Cambodia, and now Uganda. And what's been, I think there are two sort of things that have started to emerge recently. And one is that when I first started this work and also some of my academic studies on mental health and psychosocial support in developing country contexts, this was 20 years ago now, and there was a lot of skepticism, outright skepticism in some places, a lot of sort of questioning whether this was really a need, especially in contexts where people are often, very preoccupied, understandably, with survival issues. And, do they really care about mental health? Is that really a problem? And as we saw in the video presentation earlier from the doctor from UCSF, mental health affects everyone globally. It is not just a Western issue. It doesn't exclude people of any background or socioeconomic status. And the impacts can be enormous, and economically, socially, and individually. So I'm happy that over the last 2 decades, there has been this progressive awareness, increasing awareness about the importance of mental health and psychosocial support for everyone. And that we're really starting to get a lot of evidence behind that too. It's no longer just a hunch or a feeling or an observation. There's real data to support this. And increasingly, there's data to show that for development practitioners, beyond humanitarian response where mental health is often prioritized, but even in development, longer term work, we cannot accomplish our development objectives in economic growth, education, healthcare, all of these technical areas, governance even, we can't accomplish things there if we're not considering mental health. And there are sort of two aspects to that. And one is that if you're designing activities and programs, to help people develop job skills or to increase retention in schools, these sorts of things, you have to understand that people aren't showing up just 100% the ideal participant, whatever that is. They're coming there with their own experiences and backgrounds. And sometimes those experiences or backgrounds include mental health issues or include trauma, include, symptoms that can impede their ability to fully succeed in our programs. And so we can't just, build development programs in a vacuum separate from mental health. We have to think consciously about building these things into all of our programs. And secondly, when we're looking at trying to accomplish things like peaceful political transitions or decreasing crime and violence, you have to think very critically about what are some of the behavioral, mental health, social, emotional, etc. drivers behind some of these issues. So we can't, I'm thrilled that we're catching on slowly but surely, we meaning USAID in this case, of the importance of mental health and psychosocial support in our development programming, as well as our humanitarian response programming. Funding, of course, is always the question, and we are lagging behind a bit on that side, unfortunately. So we will soon have a new agency mental health and psychosocial support policy, which is the first time USAID will have a single coherent policy document about mental health and psychosocial support. And we're hoping that with that, we'll be able to also advocate more effectively with Congress, our ultimate funders, to get more dedicated funding for MHPSS in our work. Right now, we sort of take scraps of funding wherever we can find it and where we're allowed to use it for this purpose, but it's challenging when you don't have consistent, reliable, dedicated funding to just pull things together, and particularly from the perspective of building sustainability. Sorry, I have a visitor. Building sustainability and local capacity to deliver mental health and psychosocial support, you really need to have some steady funding to get those sorts of things done. And so our hope is that with this new policy and increasing awareness within USAID, within the wider development space, and even within Congress, that we will start to see that part of the change come along as well. And then I know we're over time, so I'll wrap up with just another quick reflection, which is that in my 20 years now of working in different places, either doing academic research or applied work with NGOs, or now on more of a policy and program design end with USAID, I've been thrilled as well to hear more people asking for this type of assistance. So the awareness is growing, on our end as a donor and, with implementing partners that MHPSS is important, but it's also growing among populations themselves. People are starting to recognize that mental health does not mean you're crazy. It's not, there's still lots of stigma, of course, and there's plenty of work to be done with reducing that stigma. But communities themselves increasingly are realizing that A, these needs are real, and B, there are ways to address this. So they're asking for that kind of help, which is hugely important, because you can't just plop down an intervention, especially a mental health related intervention, and not cultivate that local support and buy-in. That's critical to having effective and sustainable mental health programming. So I'm glad to see at both ends of the sort of spectrum, from the grassroots to the donor, we are starting to see this growing awareness and desire for mental health and psychosocial support programming. And my hope is that by the time I eventually retire, we'll be even farther along this trajectory. But it's because of the efforts of partners like you, and showing up in spaces like this to have these conversations and to share this evidence and get this information out there. That's how we've come as far as we have in the last 20 years, and that's what will get us even farther in the years to come. So I want to thank you for giving me a few minutes to speak and share my experiences, and I'm thrilled to share this event with so many excellent participants.
Thank you, Julie. That was really great. And thank you all for joining us today. We've just had such an exciting conversation, and I'm sad that we don't have enough time, as always. But we've seen such great progress happening in Africa and around mental health and psychosocial. So it's really great, to hear about the achievements at the Africa CDC and the scale up that's happening in Kenya and in Uganda, and to get the perspective of implementers, policymakers, funders, donors. And so we will share a summary of this presentation or this webinar, and also the recording will also be made available online to you all. And if you have any questions, please feel free to email us, and we will try to respond to those questions, and we'll summarize actually some of the questions that you all have and put that in the summary report, so you can have that there as well. Thank you again, and thank you so much for staying on over time. Have a great rest of the week. Bye.